with radioembolization at McGill, and so he'll be presenting to you that data. Mazen?
First, I would like to thank the organizing committee for choosing me to present this data, and second, I would like to thank you guys for attending. The scope of this is really just a continuation of what Dr. Chaudhry talked about, which is really liver treatment for neuroendocrine metastases, and more concentration on the experience that we had at McGill on radioembolization therapy, which is peculiar in Canada. Next slide, please. Just an overview. Why we talk a little bit much more on the liver metastasis is because it's frequent. It's 40% of patients do develop or have already liver metastasis once they have the diagnosis of neuroendocrine tumor. And the other part of it is most of the time it's actually a bilateral diffuse disease rather than a single lesion or two-lesion disease. And not only that, the fact that you do develop liver metastasis, although neuroendocrine tumor in general do have a relatively better prognosis as compared to other cancers, it does reduce the survival of the patient. So an attention for treatment for patients with liver metastasis is important. Next slide, please. Just a general scheme, the treatment plan is really mainly based on the differentiation because, as everybody mentioned already, the poorly differentiated patients, probably cytotoxic chemotherapy will come first as an option for therapy. However, in well-differentiated tumor, beside long-acting sandostatin treatment, local destructive therapy plays a major role prior to other therapies, including systemic radiation, or even we're not even still sure when to use our targeted therapy, but definitely plays a role early on in our treatment scheme. Next slide. Just in general, there are two companies who are actually working on producing these treatment substances. One is called TheraSpheres, the other is called Therasphere. And there are small differences between them. The TheraSpheres are glass microspheres. They tend to be a smaller size. The Theraspheres are resin-based microspheres, and they tend to have a larger size. And because of the size differences, they could contain larger radiation amount. However, their penetration is also different into the tissue. The end result, actually, they both produce exactly a similar effect, except they're two different companies. The radiation emitted from these beads are very limited. They're 2.5 millimeter in a range that could only be a centimeter in diameter. However, the effect of these radiation beads really long, with a half-life of 64 hours, but the effect of the radiation itself actually lasts months. Next slide, please. The way this treatment is given is the nice picture Dr. Chaudhry produced is exactly the similar way. It's a puncture in the femoral artery, passing a guide wire into the vasculature, reaching the hepatic artery, reaching to the side of liver that needs to be treated, and then delivering the radioactive material into the tumor side. The advantages of this procedure is a day procedure. For a patient who would like to be in, get treated, go home the same day, plays an important role. The other advantage, although we usually give it to patients with multiple bilateral disease, the effect on the hepatocytes, on the function of the liver, is actually minimal. So the toxicity on the liver is very low. And that is also important. However, the disadvantage is it does require the patient to come more frequently to the hospital because there's a planning that needs to be done prior to the treatment, and it's usually done at least 1 or 2 times depending on how many treatments are being given. There's also a cost relation associated with it, especially at this time when it's not covered by the government, and also availability. It's not available in many centers. Next slide, please. Just a brief, there are 2 major publications that talked about the efficacy of radioembolization neuroendocrine tumor. They're both published in 2008. One had 12 centers participating between Europe and the United States, and mainly based at the center in Chicago with Dr. Salim. They treated 148 patients with 185 treatments. And in that paper, they only concentrated on response and complications, and they had 2/3 of patients had the response to the therapy, and only 10% had a significant side effect or toxicity. Next slide, please. And the second study was more of a prospective study rather than looking retrospectively. It wasn't randomized, but it was more prospective. They call it a phase 2 trial, where you actually just want to see how safe is it and what's the efficacy of it. This was 9 centers over 5 years period to treat only 44 patients. They had a lower response rate, but also a lower toxicity. And in this study, they reported survival, but they actually did not compare it to the patients who did not got treated. It was just in the treatment group. Next slide, please. At McGill, the patient selectivity for this treatment was based on the fact that we give it to patients with bilateral multiple lesions, so they're non-operable, or they've had their operation, they reached a stage where you cannot do any more operations. And it was also based on the tumor board recommendation, where many other physicians are involved, surgical, radiology, and endocrinology. The protocol of therapy starts with the CT angiography, where they actually measure the size and the volume of the liver and the size and the volume of the tumor to calculate the dosage of the therapy. Then we do a run trial test, where we give a patient the radiation material, but without the radiation effect. So it's just the material to see, is there any shunting? Is there any escape of these resonance to the other organs to prevent side effects? And if there is, then we have to fix that before the treatment. And then we do one treatment at a time, and that's where comes the frequent visiting to the hospital. Next slide, please. We did it over a 3 years period. We had 25 patients whom had 44 treatments. The median follow-up of these patients after the treatment is approaching 2 years, and our average age of patients was 63 years old. Next slide, please. We wanted to do this over 2 phases. So in the first phase, we wanted to see what's our results in comparable to other reported results in terms of response and complications. We actually wanted to try to put this into perspective and try to identify the timing and to whom this should be given to. So we actually looked at what predictor response to the 64% or the 58% who had a response. We would like to identify who are these patients. And as a second phase, we're going to be looking at what benefit did we bring to the patient, because we know we're not curing the disease. So what we're doing, are we improving their quality of life? Are we improving their survival? Next slide, please. Talking about the first phase, 64% of the patients have bilateral disease. The majority who did not have bilateral disease are patients who had an operation, and so now they have only one-sided disease because the other side was cleared up by an operation. In this patients category, more than half had more than 1/3 of the liver involved with cancer. So we're talking about a little bit an extensive group of disease. This is on CT scan, not visual. So an overt disease on a CT scan. 28% had some extra hepatic disease that was still existent, and the majority were well-differentiated cancers. Next slide, please. On an average, we gave 127 GRADs in these treatments. Half of our patients had a 40% increase in necrosis, and I'm using the expression increase in necrosis because some of the tumors, because of their size, they necrose or they die off the middle part of it. That's not really a treatment effect. They just have that before the treatment. So what we looked at is how much increase in that necrosis we achieved. And so when we talk about half of our patients had 40% increase in their necrosis, means more than what they started with before the treatment. And the range is 32 to 47%. And 2/3 of our patients actually achieved more than a 30% increase in necrosis. Next slide, please. When we look at complications, We had actually one death related to the procedure. This was early on in 2006 when we started doing this procedure, and it was because of a shunting problem where the beads escaped the liver and went to the intestine. We learned from this experience a lot. We actually even discussed it with other involved centers, and we're more vigilant now to prevent these shunts before the therapy. Since then, we have had no shunting problems, but we do have 2 patients who developed some severe complications. One had an abdominal pain that needed to be admitted to the hospital for pain control, and the other had a blockage of the portal vein, which is not a direct effect of the therapy, but it did happen after the therapy. We have had 6 patients who have had minor complications that did not require readmission or medications, but nevertheless they had complained about abdominal pain, itching, feeling weak, nauseous, some fever, and weight loss. Next slide, please. Then we wanted to see, okay, well, we achieved 50% of our patients had 40% increase in necrosis, but whom are the patients who developed that necrosis? We looked at many variables to see which ones are more predictive and so more indicated to have that kind of treatment. We looked at age, sex, lesion size, liver involvement, extensivity, the WHO staging, the extrahepatic disease, sandostatin treatment, previous surgical therapy, means patient had a previous operation or radiofrequency ablation, or a previous non-operative therapy like an embolization or chemoembolization. And we put that into a study, and we checked each variable as a univariate analysis, and then we got the significant ones and we did a multivariate analysis. Next slide, please. So these we have had 3 positive factors, and the first one comes on the top, which are the patients who had a previous surgical therapy. And you see there are 2 lines here. There's a red and blue. The red line are the patients who did not have an operation before for the liver. And you could see that the response, which is the 1N, that's the necrosis prior to the therapy, and 1N1 is the necrosis after the therapy. There is an increase in necrosis, but not as good as the blue line, or the patients who had a previous liver surgery, and that was significant. Next slide, please. Second in line comes how much of a disease bulk in the liver. And we divide patients into 3 types: 1/3 involvement, 2/3 involvements, or more than 2/3 involvement. And the green line are the patients who had less than 1/3 involvement. And these are the patients who had a better response to the therapy, or a higher response to the therapy and necrosis as compared to the blue and the red. And that was significant too. The last predictive variable was the patients who had bilateral disease. And the bilateral disease, the positive ones are the ones in blue. The ones who had only one-sided disease are the ones in red. And the ones in red had a higher necrosis, means patients who had only one-sided disease had a better response to the therapy. And you could see from putting all these 3 together, it looks like if you have a less disease confined to one side, and not most of the liver has been involved, where you've had a previous operation, you have a better prognosis. And so saying that we should use this as a first-line therapy is obviously wrong, because if you want to give a treatment for a patient who had extensive disease in the liver, you're not going to be expecting a lot from this kind of therapy. Next slide, please. We looked at our overall survival in this group of patients. So we're not talking about all neuroendocrine patients. We're talking about patients who had TheraSphere therapy. And our median survival was 3 years. It's a year higher than the group published by Chicago, but I don't think we're not exactly comparing similar patients' characteristics. So comparison is very difficult here. Next slide, please. We also looked at, if we divided the patients whom had TheraSpheres into 2 groups, ones whom had a previous operation, not bilateral disease, less than 1/3 bulk, and a group whom had the bad signs. They had bilateral disease, more than 1/3 bulk, and never had an operation. The survival is almost doubled for the good variables. And so it all comes into a similar conclusion, that we're going to try to reduce the bulk of the disease before any kind of therapy that we provide. Next slide, please. And so, to summarize, radioembolization do increase necrosis of liver metastasis as evidenced by CT scans. The benefit are seen in patients who have less bulky disease, and as you recall, most of these are well-differentiated neuroendocrine tumor. It might imply that surgical debulking prior to treatment would be necessary to improve response. However, a larger prospective data is needed before we make concrete conclusions. This is when the balloon should pop. Thank you.